initially we'll start with the history. What is the complaint for which the patient got admitted? Most of the time it may be the pain in the breast or it may be the lump in the breast for which the patient would have got admitted. So while elaborating, you should elaborate what was the chief complaint for which patient was admitted. Usually the chief complaint, when we present, that will be in the words of the patient. But when we elaborate, it should be in the terms of medical terms. So if it is a pain, first you initially elaborate the pain, or if it is a lump, you initially elaborate over the lump. If it is a lump, so what is the mode of onset? Usually, most of the time it would have been noticed by while bathing or during a mild trivial injury, patient would have noticed that swelling, notice the lump. So usually it is insidious onset. When you say it is insidious, that means you don't know when the lump started, but it was present suddenly one day, it appeared that much size. Then what is the duration? After she noticed the lump, for how long it was there since the patient approached you? And what is the rate of growth? What do you mean by the rate of growth? Whether it is sudden increase in the size, the lump from 2 centimeter to 5 centimeter, in a period of 1 month, it is a sudden increase in the size. But if it is spans out for over a period of 8 months or 6 months, it is slowly increase in the size. So depending upon the size, you can ask the patient initially how small it was and what is the present size. So regarding the pain, usually the lump in the breast are usually painless. Even though it is cancer or a fibroadenoma, usually painless. If it is associated with pain, it may be because of the fibroadenosis or periductal mastitis or breast abscess. So you should ask whenever the patient complains of breast pain, whether it is associated with menstrual cycle. Usually if it is a cyclical pain, it may be because of fibroadenosis, which will be get aggravated before the menses and relieved after the menses. So any relationship with the menses, whether it is cyclical or non-cyclical, most of the non-cyclical pain will be usually, it will be from the costochondral margins or it is non-breast in origin. Then ask about the discharge from the nipple. Whether the discharge, what is the color of the discharge, when the discharge occurs, whether it is spontaneous or only on expression. How will you know it is spontaneous? While wearing the dress would have been stained with the discharge. In that case, it is spontaneous. Sometimes when the patient while bathing, when it compresses the nipple, you may get a discharge. Most of the time, the serious discharge may be there, which may be insignificant. And retraction of the nipple. Regarding the retraction of the nipple, we should always ask about the recent retraction of the nipple. Because the retraction is common from the congenital. If it is due to congenital, this retraction can be averted to normal. Usually that will avert to normal after pregnancy or during lactation. Recent retraction, one is because of the cancer breast, because of the infiltration of the lactiferous ducts, or it may be because of the periductal mastitis. In that case also you can get a recent retraction of the nipple. Congenital it is usually bilateral, pathological it is unilateral. So you will elaborate this on the present history, and past history you will ask any similar complaints in the past, like any history of breast lump for which she has taken any treatment. Sometimes it may be atypia for which she should have taken a conservative line of management. This may be the recurrence, or sometimes it may be even a malignancy, but patient would have not completed her treatment, or sometimes it may be just a benign breast pathology. You should ask any similar complaints in the past. And personal history is very much important in the cancer breast, because some modifiable, non-modifiable factors can precipitate the cancer breast. The marital status and the parity. Parity is very much important because increase in the number of the children, so there will be less number of cycles, which is a protective factor for the cancer breast. Nulliparous is the risk factor, and breastfeeding history. So because if it is wholly breastfed, most of the time the patient will have a lactation amenorrhea, which is again it is a protective factor. Then oral contraceptive intake. Usually the oral contraceptive intake and the treatment for infertility, both combined estrogen and progesterone has a risk factor than when it is only estrogen alone. So always ask for the oral contraceptive intake. How will you ask for the oral contraceptive intake? You can ask them if you ask oral contraceptive, they would have, most of the patient, they would have not known. So you can seldom ask, you can ask in the name of the PHC, it is given in the Malayan or Maladi, or you can ask them whether they have taken any treatment to prolong the amenorrhea or any treatment to regularize the menstrual cycle. Most of the time, without knowing, they are the contraceptive pills or the hormonal pills most of the women will take because of the irregular menstrual cycles. Dysfunctional uterine bleeding, they would have taken it for 6 months, 1 year, 2 years, sometimes even without the consultation of the doctor, they may prolong it for 5 years also. Then hormone replacement therapy if the patient is a postmenopausal. Then regarding the menstrual history, age at menarche is more important because less than 12 years has an increased risk, and menopause, if it is more than 55 years, it increases the risk of CA breast by double fold. Then family history of breast cancer, it may be from the siblings, mothers, daughters, or from the sisters in the mother's side. Even paternal side also you can ask for the history of breast cancer. And some of this BRCA1, BRCA2 also causes ovarian cancer. You can ask them any history of ovarian cancer, pancreatic cancer, male breast cancer, because male breast cancer is more common in BRCA1, and prostatic cancer. Then after completing all this, you can ask this history suggestive of metastasis. Most of the time we will ask at the end of the present history. So you will ask the common metastasis, even though it is lumbar. Most of the time the patient presenting metastasis will be for breathlessness, which is because of the pleural effusion. Then abdominal pain in case of Krukenberg or liver mets, and back pain in case of lumbar metastasis, and any history of recent fracture, which may be a pathological fracture. Then coming to general examination is a routine for all other cases, general examination. So I am not going in detail. Regarding the local examination, the position usually don't ask for the consent in the general examination. You tell consent for the examination is asked and the parts are exposed adequately. Usually for the breast examination we used to tell from the neck to the waist, but that sometimes that may not be possible or that may not be needed. So adequately exposed. Position is usually in the sitting posture, leaning forward, and semi-recumbent or lying posture. In the sitting posture, your arm by the side of the patient, arm raised above the head, and some may say that is arms kept over the hip, but on inspection, that is, you will not be able to see any difference by keeping the arms by the side. So only during on palpation you can say arms by the hip. Otherwise, arms by the side of the body are raised above the head. So what are the things you will inspect? First by the arms by the side, the size of the breast, whether it is larger or smaller compared to the opposite side, whether the breast is symmetrical, any lump is visible, any vague lump is visible. And regarding the skin of the breast, any puckering is seen, any pudgy orange. Pudgy orange, you know it is orange peel appearance, any nodules, which may be the satellite nodule, or any ulceration, or look for any fungation. Then coming to the nipple, what is the level of the nipple compared to the opposite side? Sometimes it may be elevated because of the fibrosis of the cancer, and number of the nipples. Sometimes patient may have a supernumerary nipples, 2 or 3 nipples along the milk ridge. Then size and shape of the nipple, surface, look for any cracks, any fissures, any ulcers, and discharge. Since we are in inspection, you look for any spontaneous discharge. Then the areola, what is the color? In the young it is pale pink. In the after pregnancy it becomes darkened. And what is the size of the areola? If any cyst is found just beneath the areola, it will be larger. Again, what is the surface? What is the texture? Whether any ulcerations, any cracks, fissures, any eczematous lesions, to differentiate from the pages as well as from the eczema. Whether the nipple is eroded or normally present, any retraction is seen, everything should be inspected. Then arms and thorax. If it is the lymphedema, you have a brawny edema on the arms, and you may have a cancer and cuiracy, multiple satellite nodule in the thorax. Then arms raised above the head. Again, you can look for the symmetry of the breast. Sometimes when the arms are raised above the head, You may see any lump prominence, though breast may be, asymmetry may be lost, any prominence of the lump, even the puckering becomes more prominent, the pudgy orange become more prominent, and the level of the nipple. Sometimes the level of the nipple will be not equal while the arms are raised above the head. Look for any retraction which also becomes more prominent. Then inframammary fold. Inframammary fold, usually if there is any lump which is not found normally, can be seen by raised above the head, and look for the axilla. Most of the time you won't be able to see any lump or any swelling in the axilla by inspection unless it is a grossly enlarged lymph nodes. For completion you have to say the axilla, then the supraclavicular fossa, then ask the patient to leaning forward whether both the breast falls forward or not. Most of the time we tend to say that it falls forward equally, but whenever there is a lump is there, it cannot fall forward as equally as the normal breast. So whether it is falls forward or not. So this is regarding the inspection. Sometimes if you have any doubt, you can ask the patient to present in the lying posture where the breast is laid down, and you can look for any lump. Palpation, again palpation you can see in the sitting posture, or ask the patient to lie down so that you will be able to palpate it properly. Normally, usually the flat of the, not on the hand, usually the palmar surfaces of the fingers. With the hand placed flat, with the palmar surfaces of the finger, you will palpate the lump in the breast. Start from one quadrant and move all the 4 quadrants. And again palpate the axillary tail, palpate behind the nipple, and look for any nipple discharge. So when you found the lump, look for any local rise of temperature. Usually it will be seen in case of breast mastitis, any tenderness, and number of lumps present. What is the, which present in which quadrant and extends to which quadrant. Sometimes common is the upper outer quadrant extending into the upper inner, or sometimes it may extend into the upper outer to the upper lower, or sometimes it may involve all the 4 quadrants. So which quadrant is involved? What is the extent? Then size and shape of the lump. Usually the shape we call in the malignancy, it is irregular in shape, uneven surface, and the margins are irregular. Then consistency, usually if it is malignant, it will be hard in consistency. Then we look for the mobility of the lump. So you look for the fixity to the skin. You'll slide the skin over the lump, look for any, the skin slides easily, or you can pinch the skin whether the skin is able to pinch it. That is the fixity to the skin. Then fixity to the breast tissue. Usually we say it is fixed to the breast tissue, or it cannot move independently of the breast tissue. You catch hold of the breast tissue on one hand and look for the mobility of the lump in the opposite side direction. You won't be able to, the movement will be restricted. Then fixity to the underlying muscle. If it is upper outer quadrant, you look for the, ask the patient to present in the hip and look for the anterior axillary fold tautness and movement both perpendicular direction, any fixity to the pectoralis muscle. If it is in the inner quadrant, look for the serratus anterior fixity by pressing against the wall. Then fixity to the chest wall, already we have looked it in the inspection. You can confirm it by the palpation, in which case the lump will be fixed. Then palpation of the axillary group of lymph nodes. You'll know better in the dance that how you palpate the anterior group, how will you palpate the posterior, lateral, central and apical group. These are the sites where these group of lymph nodes will be present. Again, when you look for the lymph nodes, you look for the size, the number of lymph nodes, consistency, mobility, whether they are discrete or matted, everything is important, which may alter the stage. Then look for the supraclavicular lymph nodes. Then coming to the opposite breast, again palpate all 4 quadrants, look for any lump, opposite axilla, opposite supraclavicular fossa. Then coming to other system examination, usually when you do a breast, the next system will be respiratory system or abdomen. In the abdomen you look for any hepatomegaly, ascites, any Krukenberg tumor. So even though if you are not done in the PG, you should do a PV and perectal examination. As a UG, you can say, I will do PV and perectal examination, has to be done like that. Along with the abdominal examination, look for the left supraclavicular fossa and the spine. Skull and spine are the part of the per abdomen examination. So you complete the spine examination with the at the completion of the abdominal examination. And CVS, as a routine health checkup, you do the CVS examination. After that, you will say your diagnosis, whether it is carcinoma of which side of the breast, what is the clinical TNM staging. You have any doubt till this? This I have covered the examination of the breast lump. Then you can move on to the case presentation.
Thank you, ma'am. I'll be starting my case. So, a 44-year-old perimenopausal woman, Mrs. Kala, wife of Mr. Murugan from Panagudi, who is a daily wager by occupation, came to the OPD with complaints of a lump in the right breast for the past 1 month. Present illness. The patient noticed a lump in the right breast during bathing before 1 month, initially smaller in size, the size of a lemon, and approximately of 5 centimeters, and it has now progressed to attain the present size. It is insidious in onset. It is not associated with pain or ulceration of the skin. History of recent onset nipple retraction is present on the right side for the past 2 weeks. No history of nipple discharge, no history of swelling in the axilla, no history of trauma to the breast, no history of fever. No history of any breathing difficulty, no history of cough with expectoration, no history of back pain, no history of abdominal distension or abdominal mass, no history of headache with seizures, no history of loss of weight or loss of appetite, no history of swelling in the opposite breast. Past history.
1 minute, ma'am. Go to the history of present illness. You said initially smaller in the size and the size was already 5 centimeter.
Approximately, ma'am. The patient said it was like a 2.
Then don't say it is smaller in size. Approximately it was the size of the lemon which has been increased now. Because if it is smaller in size means already maybe 2 or 3 centimeter. 5 centimeter is already a
big lump.
Already it is a T2 lesion.
Yes, ma'am.
So don't say smaller in size.
Okay, ma'am.
Will you ask for the trauma to the breast?
Usually trauma draws the attention of the patient to the lump, or in the case of it can also cause traumatic fat necrosis.
So for a routine you are asking.
Yes, ma'am.
Why history of fever?
History of fever in the case of breast abscess or any mastitis.
How long the lump was present?
For 1 month, ma'am.
Only 1 month duration.
Yes, ma'am.
Okay.
Past history. No history of diabetes mellitus, no history of hypertension.
Usually you won't get loss of weight and loss of appetite in cancer breast. Like any other malignancy in the GIT, the loss of appetite and the loss of weight will not be as prominent as in the CA breast, which is usually the patient will be normally looking and normally present.
So why did you ask breathing difficulty, back pain, abdomen distension, mass?
Sir, for metastasis, breathing difficulty for pleural effusion, and cough with expectoration is for any cannonball metastasis in lung parenchyma. For back pain is to rule out lumbar metastasis. Abdominal distension for ascites and abdominal mass for in the case of any liver enlargement or Krukenberg's tumor.
Why lumbar, not thoracic?
Ma'am, most common is lumbar, ma'am. Thoracic is also involved.
Why most common is lumbar?
From Batsen's plexus, the tumor can
How
be...
it reaches the Batson plexus?
Ma'am, from the venous drainage of the breast.
How?
In the Batsen's plexus, the veins are valveless and hence tumor seeding.
How it reaches the Batson plexus? It is the venous plexus of the spinal cord.
Yes,
How the venous drainage reaches from the breast to the spinal cord?
there is collaterals between posterior intercostal veins and...
It's not collaterals, it is the posterior intercostal veins which drains into the Batson plexus. Because of the gravity, since it doesn't have valves, the cancer cell settles down in the
pedicle of...
in the lumbar.
Apart from headache and seizures, is there any symptoms suggestive of brain mets?
Headache and seizures. Sir, any altered sensorium? In the case of space occupying lesion, there might be projectile vomiting. Usually frontal headache is the most commonly seen headache.
Then blurring of vision also you have to.
Yes. Past history. No history of diabetes mellitus, hypertension, asthma, tuberculosis, epilepsy and heart disease. No history of any previous surgeries other than LSES. No history of any drug allergies. No history of any radiation exposure.
What previous surgeries you are expecting?
In the case of any benign conditions or atypical ductal hyperplasia or ductal carcinoma, the patient might have undergone breast conservation surgery or
ATPA, you want a breast conservation surgery?
lumpectomy.
Breast conservation surgery is a term only used for a
Early breast cancer.
cancer breast, not for a benign condition. Benign condition, it may be a
Simple mastectomy.
Ma. Don't get tensed up. If it is a benign fibroadenoma, it is an excision of the fibroadenoma. Or it is a benign lump, you will do a lumpectomy. These are the two terms used for the benign condition. If it is simple mastectomy, everything is mainly for come under malignant disease.
Why did you ask history of radiation exposure?
Sir, it is one of the risk factors if the patient underwent any radiation, most commonly for Hodgkin's lymphoma, mantle radiation, less than, if she underwent
Where
less
do they irradiate for what is mantle radiation? Where do they irradiate?
for Hodgkin's lymphoma over the chest wall, Y-shaped irradiation. Risk factors, if it is less than 30 years.
Any radiation before the age of 10. So you need minimum 10 to 20 years of exposure to develop a
Breast.
If you say, if you don't know, just say that any history of radiation may be because of any disease, not necessarily Hodgkin's lymphoma.
What histopathology do you expect after a radiation exposure? What is the most common histopathology?
Breast.
Most common is ductal carcinoma.
Ductal carcinoma.
Okay.
No, yes, sir.
So, when suppose the patient is exposed to radiation, what do you expect? What pathology would you expect? The same ductal carcinoma, or you expect some other thing?
Lobular.
We'll suspect sarcoma, okay, pleomorphic sarcoma. So more than carcinoma, sarcoma is possible with radiation exposure. Another thing is, if the patient is previously treated for CA breast and has received radiation, then what would you expect? Patient has undergone mastectomy, radiation, and again she has developed a mass lesion. And what would you expect?
That might be a recurrence of
Okay,
LAPC.
it could be recurrence. As ma'am said, anything that is developing after 10 to 15 years after irradiation in a post mastectomy case.
Sir, again, primary tumor can develop. Or,
Apart from primary, something related to your radiation.
It can cause mutation and
See, again sarcoma. Okay, so the patients might have a lymphedema. Lymphedema with radiation exposure, they can go for angiosarcomas or lymphangiosarcomas. Okay, so what I would insist is, whenever you ask any history or any relevant thing, you should know why you are asking, and you should understand it, and you should also be able to tell why you are asking, and you should generalize things from that. Okay, not just asking things, no history, nothing. That is not the case. You have to understand why you are asking, and you should be able to tell the reasons behind it. Okay, and you should get an inference also.
personal history. The patient consumes both vegetarian and non-vegetarian diet. She has normal bowel and bladder habits and normal sleep pattern. No history of smoking or alcohol intake.
1 minute, ma. What do you mean by both vegetarian and non-vegetarian diet? Anybody in the world, the human being can be a pure vegetarian without, pure non-vegetarian without a vegetarian? So if it means non-vegetarian, it includes that
Both
they would
vegetarian
have
and
taken
non-vegetarian.
both vegetarian and non-vegetarian, not necessarily write as vegetarian or non-vegetarian. And what is the inference you are getting by getting a normal bowel and bladder habits in a case of cancer breast?
For routine,
Why? Will you have a constipation or a diarrhea, or you will have a dysuria?
no ma'am.
Then don't ask anything. Sir just told you, no? Don't ask anything for completion's sake. Every history should have a
Relevant.
relevance to your particular case. Not necessarily you have to write everything as in a cancer breast, as in a thyroid also you are asking for bowel and bladder habits. Not necessary. You should have a relevance here. Like that, what is the normal sleep pattern in CA breast? It has any relevance? Don't ask all these things. Do you have any relevance of smoking, alcohol intake, tobacco or betel nut chewing?
Smoking and alcohol intake, it is a risk factor for development of cancer breast.
Betel nut chewing, tobacco, oral tobacco, how does it influence CA breast?
Tobacco contains carcinogens which can cause CA breast.
It's more in favor of cancer breast or more in favor of oropharyngeal carcinoma?
Oropharyngeal carcinoma.
Proceed.
Menstrual history. She attained menarche at 14 years. She has regular 28 and 28-day cycle with 4 days of bleeding. Her LMP is on 5/9/24. So, the menstrual cycles are not associated with pain or passage of clots. No history of any oral contraceptive pill intake.
Just a minute. You say her LMP is 5/9 and you say regular cycle 28/4.
Only this cycle was delayed, ma'am. All the previous cycles, specifically the last 3 previous cycles were regular.
Where?
Regular, ma'am. 28-day cycles.
Regular. Before that?
Before that also, she said all over.
Then why you asked about the not associated pain or passage of clots? Do you have anything to do with the cancer breast? Increased flow increases the cancer or decreased flow decreases like that? So it is not necessary. This may cause trouble to you in the examination. Sometimes the questions may be asked in a various way. Why there is a dysfunctionality, what is the hormonal imbalance like that? That will be a problem. You pertaining to your case, what is needed? What is this menstrual cycle? What is this menstrual cycle, whether regular, irregular also very much important to?
CA breast, ma'am.
Why?
Because in irregular cycles, it may be anovulatory cycles causing unopposed estrogen action, which is also a risk factor for development of cancer breast.
Again, if it is irregular menstrual cycle, patient would have been taken a
Oral contraceptive.
oral contraceptive pills. Any hormonal tablets, not necessarily oral contraceptive pills. What is her age now?
44, ma'am. Marital history. She is P2L2 and she was married at 25 years, non-consanguineous marriage. Her first childbirth was at 28 years of age. Full term male child, LSCS was done, and she breastfed her child up to 2 years. Second childbirth was at 32 years of age, full term male child, LSCS was done, and she again breastfed the second child up to 2 years. Sterilization was done after second delivery.
What is the significance of breastfeeding?
So breastfeeding is a protective factor because there is increase of prolactin causes decrease of estrogen, and the estrogen effect on the breast is decreased. So.
See, first is hormonal. Okay, so most of the time during breastfeeding, the patients will be anovulatory cycle. Anovulatory. So the effect of hormones will be less. One thing. Second, the most important thing is only during breastfeeding, the maturation of the ductal cells will be complete. Okay, so right from puberty to pregnancy and breastfeeding, there will be a constant evolution of this ductal epithelium, which gets matured only after breastfeeding. Okay, so only a breastfed breast will have a matured ductal epithelial lining. So a mature ductal epithelium will be having a less chance of developing malignancy. So that is why breastfeeding is very important. Okay, so two things, one is hormone and maturation of the ductal epithelium. So why term pregnancy is important? Male child. What does
Necessarily, you can say first child, second child. There is no need for even LSCS, normal delivery. There are more than this. It is not needed.
what LSCS has to do with this patient? Nothing.
Even
See,
sterilization is nothing to do with that.
Be relevant, specific to the case. Okay, don't deviate much. Don't put yourself into trouble.
More unnecessary information you provide to the examiner, it will provoke the examiner to ask more questions.
Unnecessary questions.
So limited information to the examiner will be.
Because usually 20 to 25 candidates will be coming for the examination, and the CA breast will be given for at least 4 to 7 candidates. So the examiner will be fed up of asking the same questions repeatedly. If you provide this much information, they will be very much happy to ask more questions to you other than confining to a CA breast, which will be difficult for you to answer. So no need. What does anything to do with, even the sterilization has anything to do with this? If the patient is taken oral contraceptive pills instead of sterilization, it would have been mentioned better that it would have been safe. Otherwise, you no need to. The male child, term, LSCS, nothing is important. Non-consanguineous marriage, doesn't anything to do with your cancer breast? No. The way you present will tell the examiner that you have the full knowledge of the particular case. If you want to say unnecessary things, the examiner may think that you are not confident about your knowledge about the cancer breast. So that you are adding most of the things, isn't it? It will create a bad impression. Before summary, do you have any risk factors from history?
No risk factors.
No risk factors from the history. Okay, proceed to the examination. So go on to the local examination.
Examination of breast. After obtaining consent, the patient is exposed.
And you have written anthropometry. Have you measured the height and weight?
Yes, ma'am.
You measured it. Is it possible during examination?
Patient, I asked the patient, ma'am.
You asked the patient, then that is not correct, no?
She said when she was admitted.
Don't write anything which you have not done during the examination. Like some may used to write afebrile. You have written afebrile. Have you taken a temperature? No. Don't do that. Is it important in the case it is afebrile or febrile? If it is febrile, then it's okay. Afebrile, it is important for a cancer breast? No. Next. And again oriented to time, place. You are giving more room for more questioning. Unnecessary questioning. Pertaining to the case. More specific.
Examination of breast. After obtaining consent, the patient is exposed from the neck to the waist and is examined under adequate lighting and privacy in the following positions. Inspection. Initially it's done in the sitting position with the arms by the side. The breasts are asymmetrical with the right breast being larger than the left. Right breast.
Initially it is done or it was done?
It was
Routinely will be done or it was done in your case?
done. Routinely.
So you didn't do that?
I also did.
Do you understand my question? You said that the examination is was done in the sitting posture. That means, it means that you have done it in the sitting posture. But you told it is done. Do you understand me? ஏமா இதில் பண்ணியிருக்கேன் ஆர்ம்ஸ் பை த சைடில் பேஷண்ட்டை உட்கார வச்சு பார்த்துருக்கேன்றதுக்கும் பார்த்தேன்னு சொல்கிறதுக்கும் ரொட்டீனாக அப்படி தான் பார்ப்பேன்னு சொல்கிறதுக்கும் வித்தியாசம் இருக்கா இல்லையா எக்ஸாமில்? Proceed.
Right breast, fullness is seen over the upper, inner, upper outer and the lower outer quadrants. Pudgy orange appearance is seen over the skin in the upper quadrant and around the areola. A scar is seen over the lump in the lateral aspect. No ulceration, nodules, sinuses or dilated veins is seen. The right nipple is seen at an upper level than the left nipple. Circumferential nipple retraction is seen. No discharge is seen. Areola is brown in color. No cracks or fissures is seen.
What is that scar, ma? And you have written திடீர்னு ஒரு lateral aspect. Oh, the lump in the lateral aspect. Where was the lump in the lateral aspect?
Upper inner, upper outer quadrant and lower outer.
So where is the scar?
The scar was in the upper outer quadrant, ma'am.
Can say scar is how? What is the scar? What is the length of the scar?
1 centimeter scar.
1 centimeter scar. It's a healthy scar. Healed scar.
No, ma'am. It was
Scar
biopsy
means it's healed.
healed. 2 days before she did biopsy, ma'am.
No, that is not a
biopsy
scar. Incision is seen.
Incision.
இதுதானே?
Yes, ma'am.
ஸ்கார்னா நல்ல ஹீலா இருந்தாதாமா ஸ்கார்.
Okay.
Okay.
With the arms raised above the head, the lump becomes more prominent.
இல்ல next. அதானே அது. இது சரி.
The lump becomes more prominent. Prominence of pudgy orange appearance is seen. No dimpling or puckering is seen. Inframammary fold is normal. No swelling is seen in the axilla. No swelling is seen in the supraclavicular and infraclavicular area. On bending forward, both breasts falls from the chest wall. Arms
What do you mean by falls from the chest wall?
Falls forward from the chest wall.
From the chest wall. Both the breast falls forward. That is enough. Okay. Equally, you are having such a big lump involving all the 3 quadrants, and another breast is normal. Will both forward equally? No. So you just say both the breast falls forward. That's all. Not from the chest wall. Don't add adjectives.
Okay.
Proceed.
Arms and thorax are normal. Left breast is normal. Nipple areola complex is normal. No discharge, ulcers or retraction is seen. No swellings is seen in the axilla.
You can complete the inspection, palpation of the affected breast, and finally you can say about the opposite breast. ஒவ்வொரு தடவையும் இன்ஸ்பெக்ஷன்லையும் பால்பேஷன்லையும் ஆப்போசிட் பிரஸ்ட் பற்றி டீட்டெயில்டாக சொல்லணும்னு அவசியம் கிடையாது. ஸோ யூ ஃபினிஷ் இட் ஆஃப் தி பிரஸ்ட் இன் தி இன்ஸ்பெக்ஷன், palpation, whatever you want to do in the examination of the affected breast. Then finally you finish it off with the opposite breast. Is just know the lump found. Simple few words is enough.
Palpation, no local rise of temperature, not tender. A lump of size 11 cross 13 centimeters is felt over the upper inner, upper outer and lower outer quadrant from the 7 o'clock to 1 o'clock position.
How did you measure?
With inch tape. So after localizing the mass, the largest diameter.
The mass is hemispherical. Then how come do you measure with inch tape? How do you measure?
So the largest diameter I took.
So you mark the extent, okay. Mark the extent with the skin marking pencil from the origin to the end. From where to where you extend, mark it, then measure with the inch tape. You cannot measure like this. You understand?
Yes, sir.
So you have to mark it tangentially.
The lump is hard in consistency with well-defined margins and irregular in shape with irregular surface. The lump moves along with the breast tissue.
What do you mean by well-defined margins?
The normal tissue and the lump could be differentiated.
It is very distinctly seen in your case?
More or less. to a certain extent.
Oh, when you should be very careful when you say a cancer lump as a well-defined margins.
The lump moves along with the breast tissue. Skin over the lump is pinchable. No tethering is seen.
So tethering is inspectory finding or a palpatory finding?
Palpatory finding.
How you palpate?
Ma'am, we have to hold the lump, and when we move it sideways, the tethering will be seen in the side.
What is tethering?
Because of infiltration of the Cooper's ligaments, multiple Cooper's ligaments involvement, there will be hollowing like a seen in the skin.
Usually, the tethering or puckering is same or different?
Puckering is inspectory finding, ma'am. Tethering is palpatory finding.
See.
Why that is important? Why do you want to elicit puckering, tethering?
So to find out if it is an infiltrating lesion. In case of malignancy, when it infiltrates the ligaments, tethering and puckering occurs.
So where does the Cooper's ligament extend from?
From the dermis to the pectoral fascia.
Okay. So anything that is infiltrating in nature will involve the
Cooper's
ligament.
ligaments.
Does the involvement of Cooper's ligament, puckering or dimpling, change the stage of the patient?
No, sir. With hands placed over the hip and alternatively contracting and relaxing, no fixity to underlying muscle and to pectoralis muscle and fascia is seen. With patient pushing against the wall, the lump is movable. No chest wall fixity is seen.
It is fixity to the muscle, not fascia. How will you say it is fixed to the fascia?
Muscle.
Only pectoralis muscle? You said it is outer lower quadrant also.
Serratus anterior will also be involved.
That also be look. And it is not seen. It's no fixity to the underlying
muscle.
That's all.
With patient pushing against the wall, the lump is movable. No chest wall fixity is seen. No chest wall fixity is present. Circumferential retraction of nipple is present.
Inspectory finding, Lama, retraction. Circumferential nipple retraction is an inspectory finding or a palpatory finding?
Inspectory finding.
Then why you want to repeat it in the palpation?
Maybe while pressing on the sides of the nipple.
You said it is a recent retraction.
Recent
At the age of 44. Okay.
No discharge is present from the nipple. No palpable mass deep to the nipple. Areola, pudy appearance is present around it. No cracks or fissures is present.
You have any photo of the lump?
Yes. Left breast. Breast tissue is normal. Nipple areola complex is normal. No discharge is present. Left axilla, supraclavicular and infraclavicular fossa are normal. Examination of lymph nodes of the right side. Axillary group of lymph nodes. A single firm, mobile and non-tender node of size 2 cross 2 centimeter is palpable in the central group.
Then you finish it off in the same side of the disease. Then you go on to the opposite side.
Okay. Level 2 nodes. Supraclavicular fossa and infraclavicular fossa, no nodes are palpable. Percussion, no dullness is heard over the parasternal region for internal mammary nodes.
But you have no nodes palpable in the anterior axillary or pectoral group?
No, ma'am.
Only the central you are having the node?
Yes, ma'am.
So it go directly to the central group?
Usually anterior is involved, but anterior and central both the groups can be involved initially.
Okay.
Other system examination, respiratory system. Normal vesicular breath sounds are heard. Abdomen is soft and not distended. Umbilicus is in midline and normal. No hepatosplenomegaly is present.
Why hepatosplenomegaly?
Any metastasis to the liver parenchyma.
Spleen.
Hepatomegaly.
You will be the ideal candidate for the exam. Don't add on the adjectives. That will create an image that you don't know what is the common site of the metastasis in the abdomen. Each and every word will tell you about your knowledge.
What other mass you look for in abdomen?
Krukenbach's tumor.
Where will you look for that other mass?
Sir, in the right or left iliac fossa.
Will it be seen, visible, or palpation?
Palpatory finding.
On palpation, will you be visible Krukenbach tumor? You will be able to palpate?
Depending on the size. Usually,
Which is
sir, metastasis to the ovary resulting in Krukenbach's tumor.
how it reaches the ovary?
Ma'am, either through drop metastasis, transcelomic spread, or through blood spread, emptogenous spread,
Blood spread.
emptogenous. Usually transcelomic spread, ma'am.
So the classical presentation is in a menstruating patient, there will be
Bilateral.
there will be follicle rupture and there will be a defect in the surface epithelium. So when there is transcelomic spread, the droplet spread, the cells gets deposited, they enter into the ovarian parenchyma. That result in Krukenbach tumors. Krukenbach tumors are usually bilateral and they are solid.
Yes,
Okay.
solid tumors. Examination of spine and cranium is normal. Central nervous system, no focal neurological deficit
Okay,
is
go
seen.
to your diagnosis, ma'am.
Diagnosis, a case of malignancy of the right breast, TNM stagings T4B, N1, M0, stage 3B, locally
Why
advanced.
T4B?
Ma'am, the tumor size is, irrespective of the tumor size, there is purely orange appearance, which is skin involvement in B, T4B.
Okay.
Basically, as a undergraduate, you should be able to differentiate. See, you're committed as malignancy, so you should be able to differentiate whether it is a benign lesion or a malignant lesion. Okay. So what are the points that favor malignancy in this patient? Because I tell it is a phylloids tumor, benign phylloids. Okay, there is a possibility. A tumor of this size, this age group, it can be even phylloids. So you should be, as an undergraduate student, you should be able to tell why you are telling it is a malignancy.
Sir, first is progression of the disease within 1 month.
1 month
it has,
progressive
progressed.
increase in
Recent onset nipple retraction is present, and the nipple is also drawn towards the tumor.
What else? You said purdy orange.
Purely orange.
You said palpation of the
Axillary lymph
axillary lymph nodes.
nodes and painless.
Purely orange. So all these inspectory findings, moving along with the breast tissue, hard in consistency, okay, all lymph nodes, all these point towards malignancy. You should be able to substantiate from your history and examination. You should be able to substantiate that it is a malignant lesion. Okay. Okay, it is a locally advanced breast cancer. So now what are you going to do?
Sir, triple assessment is done, clinical examination followed by imaging and pathological examination. Core needle biopsy is done for this case.
So first you have done a clinical examination. Then what will you do?
Imaging, ma'am.
What imaging?
Mammogram of the opposite breast is done.
What about this breast? Triple assessment is for this breast, no? What will you do for this breast?
Will you do mammogram for this?
Palpable mass,
affected
usually we won't do mammograms.
We won't do one.
Palpable mass.
Why?
It's a old theory, Madala.
You should do. Why?
So now for multicentricity or multifocality to roll out.
So you need to know whether it is multicentric or multifocal. How do you know it is multicentric or multifocal?
Mammogram.
You should do. All the more reason you should do. So one thing is, here the lump is too big. Okay, so you need to know whether it is multicentric or multifocal when you plan for breast conservation. Okay, so when you plan for breast conservation, it is must you should do mammogram on the affected side also. Okay, so you were talking about a scar. What do you think about that scar? Was that right?
Incision, sir.
Was that right? The procedure, some procedure has been done, right?
Yes, sir.
Is that right or wrong?
Core needle biopsy, right only, sir.
For a core needle biopsy, the incision was insignificant.
What was the size of the wound?
So 1 centimeter.
1 centimeter.
Have you seen the core needle?
Usually core needle biopsy
Only a punched out defect will be there.
Have you seen a core needle biopsy gun? It is just 2 mm or 3 mm. So we were thinking some incision biopsy has been done. See, you said there is a scar.
Yes.
Actually, it was not, it should not be mentioned as a scar. Even if it is a wound, we thought it is it was an incision biopsy that was done. Okay, leave it. So so you do a imaging of the affected side and the contralateral side. Then you do biopsy. What is the biopsy that you prefer?
Why you want to do a core needle? You told core needle. Why you want to do a core needle, not an FNAC?
I mean, core needle, there is more tissue for assessment of receptor status, and the differentiation of tumor can also be assessed. And the type of tumor,
Differentiation of the tumor.
well differentiated, moderately differentiated, or poorly differentiated.
It is the grading.
Grading.
Then
And then if it is a ductal component,
Is it well differentiated, mild, moderately differentiated in breast? Is that the grading we use? What is the grading we use in breast? See, you should be very specific. In breast, we use modified Scarf, Bloom, Richardson grading. Okay, it is not well differentiated, moderately differentiated. Okay. Okay. See, the very basic you do core needle is you want to know whether it is an invasive malignancy or a in situ. With FNAC, you cannot tell it is a invasive malignancy, invasive tumor. So you need tissue to tell there is invasion. Okay, only when you have the basement membrane under a microscope you can tell it is invading or invasive carcinoma. So that is the first thing you should tell. And second thing comes all your hormonal studies, everything. Another thing is, it is very easy for a pathologist to report a histopathology rather than a cytology. Cytology is difficult. It differs from pathologist to pathologist, but most of them will be well versed with the histopathology. Okay. Another thing is, why you want to do a this thing?
core needle.
Core needle biopsy. Because this is locally advanced breast cancer. So this patient will go in for some form of neoadjuvant therapy. So before you take up the patient for surgery, this patient will be subjected to some form of neoadjuvant chemotherapy. So because of your treatment, she can have a complete
regression of
regression of the tumor. So after surgery, you might not have any tissue for receptor studies. So before you subject the patient for any neoadjuvant treatment, you should know the invasiveness of the tumor, the grading of the tumor, as well as hormonal status. Okay, that is why you do core needle biopsy. So you should ask the postgraduate in your unit to demonstrate the core needle gun, how the biopsy is being done. See, it cannot be imaginary. So breast is very common. You should know all these things.
Even lymphovascular invasion can be seen, which is also more important for the prognosis of the disease.
Okay, you have done a core needle biopsy. The biopsy has come out as infiltrating ductal carcinoma, some grade. What are you going to do next?
next is
You have confirmed the diagnosis.
staging investigations should be done. CECT.
Metastatic workup.
Metastatic. CECT.
We won't say it is a staging. Here you say a metastatic workup. What will you do for a LABC?
CECT chest and abdomen, and skeletal survey, X-ray of the spine and long bones, and along with the skull, and then bone scan can also be done, or PET CT.
You have done everything. You have done CECT abdomen, CECT chest, you have done a PET CT.
No, ma'am.
Then?
Only
Or PET CT. So normally PET CT is not routinely needed. For your exam point of view, if it is an LABC, you tell it is a
skeletal survey
CT chest,
CT
CT
chest.
abdomen
and skeletal survey.
and skeletal survey.
So
If
what
it is an early breast carcinoma, you can say it is a ultrasonogram abdomen, X-ray chest, and any symptom. If there is any symptoms, you can go on for a CT.
So basically what investigation you have in your college, you tell that. So we don't have a PET CT here. So what is being routinely done, you tell that. That will be safe for you. So non-metastatic. What are you going to do?
Sir, first is neoadjuvant chemotherapy.
Why?
Sir, to decrease the tumor size and
Is that the reason?
in order to stop the proliferation of the disease also.
See, what is the problem with LABC?
Sir, it can cause skin and chest valve involvement and can wrap.
No. See, the main problem with LABC is micrometastasis. Okay, it is not the local disease or the regional disease that is going to bother the patient. Okay, so when you are dealing with malignancy, you focus your things on survival of the patient. Okay, so most of these patients will die of distant failure. Distant failure means they will develop metastasis somewhere in the body and they will die of disease in the metastasis due to metastasis. So the first thing is you should address those micrometastasis which is present in the circulation or in the target organs which the imaging you have done is missed. Okay, you understand? So you have done some imaging and the imaging doesn't show any metastasis, but any tumor that is less than 1 centimeter, there is a possibility of being missed in your metastatic workup. So these patients will have a higher chance of micrometastasis which has to be addressed before you go and treat the local and the regional disease. So that should be the first point. I will treat the micrometastasis first. Okay, so for that you choose neoadjuvant chemotherapy. So that is one point. What is the second thing? Do you think you can go and operate this patient? Some 13 centimeter size tumor with pudgy orange. Do you think you can operate?
No, sir.
So the next point is you have to downsize the tumor. So that is the next thing you expect by giving a neoadjuvant chemotherapy. So you make it into operable. Okay. So by your clinical examination you think it is inoperable. Okay. You cannot bring a closure or you cannot remove the tumor completely. You are in a doubt. So you want to bring down the size of the tumor. So that is the second thing. What is the third thing? See, you have a tumor in front of you. Okay, so you are giving neoadjuvant chemotherapy. With your own eyes, you can assess the response to the chemotherapy agent. Okay, suppose if you have operated and if you are giving chemotherapy, suppose if there are any micrometastasis, you cannot know, you will not be able to know whether it has responded or not. So by giving neoadjuvant chemotherapy, by looking at the response of the lump, you can assess the response of the micrometastasis. So that is the third point. Suppose if the tumor has completely responded or it has completely disappeared, okay, it means the micrometastasis must have also been completely disappeared. So that is the inference. So for these reasons you give neoadjuvant chemotherapy.
Always remember that CA breast is a systemic disease. So always do a systemic chemotherapy first, followed by the local regional treatment. So you have done a neoadjuvant chemotherapy. How many cycles will you give?
4 cycles, ma'am.
4 cycles.
Totally 8 cycles initially.
Totally 8. Why? Usually we will give As per New Bailey, it is only 2 cycles. You will assess the response. How will you assess the response?
RESIST criteria.
What is it?
Complete responders, no
No, no. What is this resist criteria? Resist. Expansion of resist
response evaluation criteria for solid tumors.
in solid tumors.
Solid tumors.
Okay, whether it is responded or it is a static disease or a progressive disease. If it is a response is good, it is a complete or partial responses, you continue with the chemotherapy, you complete the chemotherapy, then proceed with
Modified radical mastectomy
followed by
radiotherapy,
followed by
hormonal therapy,
depending upon the receptor status. ERPR positive, premenopausal. What hormonal therapy will you give? Tamoxifen. And if it is L2 positive,
targeted therapy, trastuzumab is given.
you will give immunotherapy, targeted.
Trastuzumab.
So what is the normal chemotherapy routinely used for neoadjuvant?
Cyclophosphamide and adriamycin.
3 drugs, no?
Paclitaxel also. Paclitaxel.
Taxol is usually in the second line.
A CAF regimen.
CAF is
cyclophosphamide, adriamycin and fluorouracil.
5-fluorouracil. If it is not responded only, they will go on for a second line of chemotherapy.
Paclitaxel.
So what are the indications for adjuvant chemotherapy?
Tumor size of more than 0.5 centimeter in size, locally advanced.
0.5 centimeter. More than 5 mm you are telling.
1 centimeter.
T2 lesions. 5.
So 0.5 for HER2 positive. So any tumor HER2 positive, 0.5 more than 0.5 centimeters, you give adjuvant chemotherapy. And any tumor more than 1 centimeter, you give ERPR positive, HER2 negative tumors, you give chemotherapy, adjuvant chemotherapy.
Then if it is triple negative,
chemotherapy along with carboplatin based regimens can also be added.
you should be ordered with the carboplatin.
Based regimens.
What about adjuvant radiotherapy?
Adjuvant radiotherapy, if it is more than 5 centimeter in size, high grade tumor with lymphovascular invasion, with the presence of residual margin.
Not necessarily residual margin. You have done a MRM, ma?
Yes, ma'am.
MRM will be there any residual margin?
No, ma'am.
Then?
Inadequate axillary lymph node dissection. If it is less than 10, we have to give radiotherapy. Or
Positive lymph nodes. As I use is a positive lymph nodes, more than 5 centimeter, lymphovascular invasion. You can do adjuvant radiotherapy. Or you can give a radiotherapy in cases of a. Can we do a breast conservation surgery in this patient?
if after chemotherapy, if the tumor size is downstage and if it is the tumor and the breast ratio, if it is decreased, we can try more.
Can go for a breast
Conservation surgery.
So what is the components of breast conservation surgery?
Ma'am, first is breast conservation surgery with followed by radiotherapy.
Should be BCS always with a radiotherapy. So what are the contraindications for BCS?
Contraindications is tumor size more than 5 centimeter or the lump and the breast ratio is more, and any contraindications to radiotherapy like pregnancy, especially the first and second trimesters, and presence of any collagen disorders like systemic lupus erythematosus and ankylosing spondylitis.
Absolute contraindication?
Diffuse microcalcifications.
It's multi? But it's
Multicentric,
multicentricity. So what is multicentricity? What is multifocality?
Multicentricity is presence of more than 2 tumors and more than
More than 2 tumors.
if it is present in more than 2 quadrant, more than 1 quadrant, different quadrants is multicentric. Multifocal is it is present in the same
quadrant, multiple sites at the same quadrant. So you can do BCS in case of a Multifocality not in a
multicentric.
multicentricity.
What is the absolute contraindication for BCS? See, initially it was five things, but now they have reduced to only one.
Sir, lymph node positivity.
Inflammatory breast cancer.
Inflammatory.
Okay, that is the one absolute contraindication for breast conservation. And as you said, components of breast conservation, it includes lumpectomy
And
and axillary lymph node dissection if it is axilla positive, or a sentinel lymph node biopsy if the axilla is negative. So always you should address the axilla also. Okay, so what is sentinel lymph node biopsy?
Sir, usually it is done in clinically impalpable nodes, technetium-99 sulfur colloid, or more commonly methylene blue can be used.
Clinically as well as radiologically non-detectable.
Yes, methylene blue dye is used, and it is injected in the periareolar or around the tumor site. And
What is the concept, ma? Sentinel lymph node.
ma'am, the first drainage of the tumor is
Yeah,
to
the first
sentinel
node.
lymph- first node.
First echelon group of
First, so if it is positive, it is an indication for dissection of
It
other
means
nodes.
there is a possibility maybe of involving other nodes. If it is negative,
If it is negative, we can leave.
So can you do BCS for this patient, for your patient?
பண்ணலாம் if it is downstage tumor size has been reduced, you can do a BCS அப்படின்னு சொல்லுவாங்க.
So you should mark the tumor
Original
location
tumor site.
prior to chemotherapy.
chemotherapy.
Why?
Sir, because sometimes there can be complete regression of tumor, and we will not be able to identify the original site of the tumor.
If it is completely regressed, still you want to do a mastectomy or BCS, or you can just observe the patient.
Observation is enough. But
No, again sir has told it is a
LABC.
micrometastasis which will be usually present. So for cancer breast, even it is regressed completely,
We should
we should do a
modify that.
surgery, modified radical mastectomy or BCS depending upon the size of the lesion.
Till date there is no cure without surgery in cancer breast. Okay, even if there is complete regression of tumor after neoadjuvant chemotherapy, you should proceed with some form of surgery, either BCS or mastectomy. Surgery cannot be omitted as of now. Okay. Okay, very good presentation. Except for that elaborate thing, so okay.
Thank you, ma'am and sir, for the most useful session.